Thank you all for being here. This is the formal kickoff of our Health Innovation Pavilion, really a center point for science and technology. We are excited to have you here. We're excited to be showcasing what can be done at the intersection of science and technology, and to showcase 3 days worth of several dozen panels, working discussions, even a health tech competition, and really to join with you and a wide range of speakers, over 100 leaders in academia, clinical outcomes research, and also in industry. And please, we look for active engagement and participation, and please also spend some time with our exhibitors. Many of them are going to be speaking as well, but also showcasing and demonstrating their solutions and products on the show floor with us. Thanks for being here at our 100-year anniversary in Chicago, where it all got started, and also to help us think about what we can do in the future for the second century, increasingly thinking about how to do partnerships and collaborations. Yes, I use the P word. We know at the AHA that it's going to take collaboration to really solve healthcare problems of the future. Again, thinking about digital health, health tech, and AI, how we can blend brand and science into powerful partnerships to get done what we need to get done and solve real problems in healthcare. Special thanks to our own Dr. Pat Dunn, with whom much of this would not have happened. He's an extraordinary guy. Most of you know him, of course. He's helped put this together. And also to our health tech advisory group, led by Dr. Bob Harrington, and our AI task force, led by Dr. Lee Schwamm. And these folks have really helped us think about the panels, the speakers, and what we want to accomplish here over the next few days. And I just thank them and thank Pat and the Center for Health Tech and Innovation team as well. Welcome, and I'm going to turn it over now to Dr. Basit.
Good morning, everybody. Thank you for coming. It's so wonderful to be here at the 100th anniversary and talk about AI and health tech. Let's see if I can get this thing to work. Maybe? Yes. Maybe not. There we go. So as I was prepping to this talk, I got to look back in history to talk about what health tech really was in the past 100 years, and really wasn't existing. Oh, point the clicker that way? Perfect, I can do that. So when we look at the century in progress, we talk a lot about technology. And what's rarely mentioned is the algorithms and the software that has really driven this technology and made it actually possible. We talk about EKGs, and I want to take a moment just to look at this quote. So the next major advances will be the that is not what I wanted. Could we go back to my slide, please? Thank you. So I'll just go to the bottom of this. The continuing support of the American Heart Association will provide inclusion and policy remains in critical importance to maintain progress. We need to bring technology and these solutions to the broader population to provide value for everyone, and technology will democratize this approach to so many people. So this was the 100-year vision for what we did from the American Heart Association Presidential Advisory Forum. And inside of this, they had this really great visualization that showed a timeline of the major milestones of technology that happened over that time period. And I want to take a moment to highlight some of these. So if you look early on in our journey, soon after the American Heart Association was founded, we received a Nobel Prize in Cardiology for the invention of EKG, or electrophysiology. And that's been a transformative field that we identified that the heart had a conduction system. We needed some really advanced technology to take that from an experimental model to something that can actually be used in the clinic, and I'm sad to say it hasn't changed much since then. So for some of you young innovators out there, I think it's really time for an EKG overhaul. If you look a little bit into the future, the acceleration at which technology was advancing has been astronomically amazing. The Framingham study was 1948. it still, to this day, creates positive impact in the care and management of our patients. Probably could be expanded to be a little bit more diverse, but really amazing. We had computed tomography, we had echocardiography, and additional treatments. But if we are to jump ahead to the next decade, the acceleration continues. I think we need a radio frequency one. So here you can see the major milestones, and a requirement of my employment is that I have to point out the Brown and Goldstein Nobel Prize for the discovery of the LDL. And that has really opened up things that we really care about. But this is the last decade. Look at the acceleration of the innovation that we see. And nowhere on here is AI. It used to be that you'd come to these conferences and you needed an AI system to help you find the AI sessions. Now, I think you'd be hard-pressed to find a session without some element of AI in it. It has transformed cardiology, and we're really at the cutting edge of what is possible at that. So this is the time to really get out your phones. I have taken and put, I think we need better technology for our remote. So this is the next 100-year plan for the American Heart Association. If you look on the left, that was in this article, that is a learning health system. Learning health system is where we more rapidly identify problems and build solutions to help solve those problems. And we need to have better solutions to accelerate that path. Faster identification, faster analytics, faster solutions, so that we can be more agile and more reactive to the new challenges that are coming. And the infographic on the right shows the major milestones that we're working on. And I think the transformative force is really here in this room, where we have the understanding of the data and understanding of the system to rapidly implement these technologies so that we can provide better care to our patients and our communities. So here are the sessions, and I'm going to highlight some of them for you. If you are interested in advanced technology, we have created things to help you understand what they are, what they can do, and how to use them safely. There are some gigantic pitfalls along the way. So if you're interested, there are definitely sessions designed for that. And I'd like to point out the bottom one. Now, we on the academic sides can't actually do this session because we like to have gender equality in all of our sessions. But women in tech is a phenomenal idea. It's going to be here at the Tech Pavilion, and I encourage everybody to come. If you have issues implementing things into commercial EHRs or commercial systems, we've designed this top session at 9:45, total disclosure, I'm presenting in it, on how to get guidelines and algorithms implemented in commercial EHRs to the bedside, to clinicians and patients to improve care. If you've ever thought, how do these people do it, this session will help you along the way. And then we have pixels to predictions so that we have also imaging technology as well. And for the first year, we have a main event focused on health tech. Dr. Peterson, who's going to be talking a little bit later, will be helping moderate that session. And they'll be talking about how health tech has transformed everything from imaging to care to guidelines, and also focus on what the next years of health technology is going to be. I did not volunteer for this session because I think that is enormously hard, but Dr. Arnaud is amazing. If anybody can create a vision of what that's going to be, it'll be there. We need to represent the importance of health tech, and they put us at the ripe old time of 8 o'clock on Monday, so I encourage everybody to come. Our representation will continue to show the importance of it and will help guide the AHA on what they put resources towards. On Monday, we have more guideline implementation challenges and successes for people who've been able to get that actually through. And then we have a health tech implementation side on how to get things to the bedside. If you have novel technology and you're interested in getting to the bedside, this is the way to do it. We have some poster sessions, so if you want to take a quick pictures of this, these are amazing opportunity to look at cutting edge sessions that will become oral presentations in the near future. And these are the ones that we have on Monday as well. So I'll leave you with this quote, which is, I conclude that though the individual physician is not perfectible, the system of care is. And the computer will play a major part in the perfection of the future care systems. And we always talk about having, and this was Clem McDonald in 1976. And that is just as true today as it was then. And I think we have plenty of opportunity to provide better systems of care for our patient and use technology efficiently. I'll pass it on to Bob, Dr. Bob.
Nicely done for setting us up for a fantastic few days based on health technology. My job is to start getting us through what we're actually doing here in the health tech world of the Heart Association. And as already been said, we're celebrating our 100th anniversary this year. And really why we brought together the health tech world into the Center for Health Technology Innovation was to do what AHA does best. AHA does best by facilitating, convening, bringing people together. And so really what we're trying to do at the AHA through the Center for Health Technology is we're trying to bring together science, guidelines, the evaluation of evidence, and technology, and taking all of that together in a way to have better outcomes for our patients. This is the group that are many of the AHA volunteers who are spending time in their volunteer time to help lead AHA in this vision for health technology and innovation. You'll meet some of them this morning. I hope over the next few days you meet many more. Let's talk a little bit about what's going on here, at least in part, which is the Center for Health Technology Innovation Innovators Network. We talked about what the AHA is trying to accomplish by bringing together scientists, evidence evaluators, and technologists, entrepreneurs, and this comes together in our Innovators Network. These are innovators, entrepreneurs, who have come up with ideas around technology that they want help. They want to understand, how does this fit into clinical care? How does this fit into how cardiologists and neurologists think about taking care of patients? And importantly, what does the AHA think in terms of the level of evidence that's required to actually make this something viable? So we have 55 members of our Center for Health Technology Innovation Innovators Network. This has been our busiest year with 33 new member companies. Many of them you'll see around in the kiosks here, and please do stop by to visit them. What it allows and what we offer from the AHA perspective is to give people the opportunity to establish research collaborations with community physicians, with academic physicians, with health systems, with the AHA. It allows the individual entrepreneur to really start to affiliate with the AHA. What is the AHA about? The AHA is about science. And for a lot of the entrepreneurs, that's what they want to their own company to be affiliated with. Gives them access to a network within the AHA, and it allows the innovators to participate in sessions like this, including at our major scientific sessions held every November. Here's some of the Innovative Network members right now. As I said, a subset are here on the Health Pavilion floor. Others you'll see on the main exhibit floor. So please do stop by, ask questions, talk to the technologists and entrepreneurs about what they're trying to accomplish, and ask them, how is the AHA helping them do that? With that, I want to thank you for your time, and I'm going to turn the podium over to Dr. Alexis Beatty from the University of California, San Francisco.
Thanks, Bob. I'm really excited to be here today to share in this celebration of 100 years of innovation with AHA. Oops. All right. Okay, so I want to talk about how American Heart Association and the science that American Heart Association supports is being applied to solve real problems right now using technology. And I think this also gives us a window into the future of how we can continue to innovate to use technology to solve real problems in cardiovascular care. So the problem that I focus on most is this area called cardiac rehabilitation. For those of you who don't know what it is, it's a multidisciplinary program for people who have had a recent heart disease event, like a heart attack or a stent placement, a heart surgery, heart transplant, or also for people with chronic stable angina and chronic heart failure. Usually people attend cardiac rehab sessions 3 times a week for 12 weeks at cardiac rehab centers. Cardiac rehab focuses on these 5 core health behaviors: physical activity, healthy eating, tobacco cessation, medication adherence, and psychosocial wellness. And cardiac rehab has been studied a lot, and we know that it has important benefits. So it helps keep people out of the hospital, helps people live longer. People who participate in cardiac rehab feel like it improves their symptoms and their quality of life. And because of all of these benefits, it is strongly recommended by American Heart Association guidelines. Okay, so this all sounds great, right? We love it. Cardiac rehab's great. So what's the problem? Well, the problem is that only 1 in 4 people who are eligible for cardiac rehab in the United States even attend 1 session. So we have this great guideline recommended beneficial therapy, but we're not getting it to all of the people. Beyond that, there are huge disparities in cardiac rehab. So there are these areas that we call cardiac rehab deserts, where there are either no cardiac rehab centers or whether there are too few cardiac rehab centers to service the population. Some of these deserts are, as you can imagine, in rural areas, but some of these deserts are actually in urban areas where they just don't have enough cardiac rehab centers for the people. There are also individual level disparities. We see that women, historically minoritized populations, and people with less socioeconomic advantage are less likely to attend cardiac rehab. So we have a big problem. We have a great therapy, but we're just not getting it to the people. So we ask the question, is this a problem that technology can potentially help us to solve? And so we look at some of the barriers. What are some of the barriers that people have to going to cardiac rehab? So one of them is transportation. So for instance, I live in San Francisco. Some of our patients have to take 3 buses to get to our cardiac rehab center. So even in an urban area, it can be difficult for people to get to that cardiac rehab center to get cardiac rehab. There are also competing responsibilities. A lot of our patients work. A lot of our patients have caregiving responsibilities. And so it's really hard for them to come 3 times a week to the cardiac rehab center to be able to get this therapy. One of the other big barriers that we see is cost. So there's both cost that's related to money, like copays. People have to pay like $20 or more for every cardiac rehab session. So for people with limited means, that's a lot of money. There's also the time cost, though, because it takes a lot of time to drive to the cardiac rehab center, get there, drive home, and so that can mean for a lot of people lost wages for them and their caregivers. So there's lots of barriers to cardiac rehab, and I do think that technology can help us to overcome some of these barriers. People have looked at whether providing cardiac rehab through telehealth, virtual, digital, technology-enabled means can help to deliver cardiac rehab. And it turns out that delivering it through those newfangled ways using technology actually works just as well as delivering cardiac rehab in the center, in the studies that have been conducted. And so we think that this is a way that we can use technology to help us solve a problem. This is one of the silver linings that we've had during the pandemic. So during the pandemic at UCSF, when we closed down our cardiac rehab center, we very quickly shifted to providing cardiac rehab virtually. And so after we came back from the pandemic, we said, you know what, this actually really helps us because we can't provide cardiac rehab to all of the patients who need it in our urban center. We actually need to provide cardiac rehab virtually to some of our patients in order to get everybody through the pipeline. And so we've kept going with providing virtual and what we call hybrid cardiac rehab, even post-pandemic. And the hybrid cardiac rehab is a mix where, say you have a person that you're not sure if they can really exercise safely. You bring them into the center, you do some sessions with them in the center, they build their confidence, they build their strength, and then you transition them to the home program. So it reduces the burden on the patient by participating in cardiac rehab using technology. And the American Heart Association is supporting a lot of the science that's behind this, and they're also supporting studies to demonstrate the efficacy of models like this for improving outcomes in people with heart disease. So one of the studies that the American Heart Association is supporting, they're supporting it through one of their strategically focused research networks, SFRNs. And this study is led by a colleague of mine, Seth Martin from Johns Hopkins, and Francoise Marvel, who I see in the back here. And they're going to be presenting later today at about 1:30 at a session on the future of clinical trials. And I encourage you all to attend that, because you'll hear about this MTAC rehab study where they've taken their platform, CORI, and they're looking at the effects of using this platform, CORI, on functional capacity and cardiovascular health metrics. And I think we're going to see a lot more research to come on using technology to help deliver cardiac rehab in the future. And I'm also conducting a study that's a multi-center study that is looking at the implementation of telehealth cardiac rehab versus traditional in-person cardiac rehab. And that's a large multi-center study, and results on that will be coming in a few years. But that will provide more evidence that this approach can really improve access to cardiac rehab for people who need this service. So that's one example of how the American Heart Association is supporting science that can help us solve real problems using technology. And I want us to spend a little bit of time thinking about this sort of future state that we might live in, where we use technology to help us solve real problems in cardiology. And so you can have your patient here who's living out there in the world now, and they have a smartphone for the most part. And this smartphone has apps, it can send text messages, there can even now be AI on the smartphone, or you can get it from the cloud. And then let's not forget that that smartphone can also be used for more traditional purposes, like voice calls, to talk to an actual human. It can also be used for video calls, to interact live over two-way audio-visual means with a human. And this person also can have a variety of different devices. And these can be fancy devices like a smartwatch. These can be also less fancy devices that have been around for a while, like a blood pressure cuff. And all of this data that the person can collect on themselves can be sent to the cloud, where we can use algorithms, AI, all of these things to help us understand this massive amount of data that can be generated by the person in their everyday life, because in their everyday life, they are not in the doctor's office all the time. And then that data can also be sent to the clinician. But the clinician, isn't going to know what to do with this mountain of data. You need smart solutions to help us figure out what does all this stuff mean, so that you can send us actionable insights so that we can actually help take care of people better. And then that frees up the clinician to spend more time having meaningful human interactions with the patient. And what we've found from a lot of our research, when we actually talk to patients about their experience participating in virtual cardiac rehab, we've found that they like having the technology. They view the technology as a tool to help them get this service. But they actually still really like having that connection with that human, with that coach who helps to keep them accountable and helps to give them that human touch to keep things going. And I do think that a lot of these features can be facilitated by technology, but I actually don't think that AI or technology will completely replace the humans, just because we do still like having those meaningful human interactions, and that's a big part of our health and our social well-being. So one other project that I want to tell you about that also leverages some AHA science is a project that I'm working on. So we were recently funded by the AHA's Healthcare by Food initiative to study an intervention to try to get people participating in cardiac rehab to join a food as medicine program. And so food as medicine programs, for those of you not familiar with them, are programs that help provide people with nutritious meals or nutritious groceries. These programs are especially helpful for people who have food insecurity, but they can also be very helpful for people who have what we call nutrition insecurity, who just aren't getting the right nutritious food that they should be getting. And so we're testing 2 interventions through this AHA-funded science. One of the interventions is a text messaging intervention to help people understand healthy eating and to get them to sign up for the healthy eating program, the Food as Medicine program. And through this intervention, we actually link to a lot of American Heart Association resources about healthy eating and healthy food. And so the results of this trial, the trial is ongoing, so we'll have results in the future. But the Healthcare by Food initiative is sponsoring a lot of innovations, including the use of technology to help us understand how better to provide food as medicine to patients. So I think to conclude, there's a lot of us who are working on building the scientific evidence for using technology for healthcare. But I think there's still a lot more work for us to do. And I'm really looking forward to seeing what we can do in the future in the next 100 years in terms of using these innovations to help us solve real problems in healthcare. And with that, I'll invite up Dr. Lee Schwamm.
Hi, everybody. That was a wonderful talk, Alexis, and I think you've highlighted the fact that the hardest problems are the ones that appear perhaps simple on the surface or not particularly transformative. I would argue this is the high-hanging fruit. This is not the low-hanging fruit that's not worthy of our great minds. This is the high-hanging fruit. Let's see how well I do here. There we go. All right. So I'm going to talk to you about a program that the AHA is in the process of launching in collaboration with the speaker who will follow me. And it's called the Connected Care Initiative. And I've kind of given it a tagline here, connecting the dots after discharge. I think we all know that the biggest point of vulnerability is after you leave the hospital. AHA's done an amazing job with Get With The Guidelines in ensuring that evidence-based care is initiated in a systematic and equitable way for patients when they're in the hospital. If you know they've had a heart attack, if you know they've had a stroke, if you know they have diabetes, you know what you need to do. The problem is, for those to be effective, they have to endure beyond the initial hospitalization. And that transition to home is a point of huge vulnerability. And just to give you some sense of the numbers, if you look just at heart failure, and you ask the question, who is eligible for this goal-directed medical therapy, quadruple therapy? We know that it works. 82% of patients are eligible, but unfortunately, only about 16% actually get prescribed that treatment. So we have an evidence to practice gap there. In addition, we know that there are substantial benefits in mortality. So the 12-month all-cause mortality for patients with heart failure who do not get GDMT at discharge, get none of it, 36%. That's enormous. Get the therapy, 12%. It's still a disease that's incredibly lethal, but that's not a gap that we should allow ourselves to be comfortable with at all. We should be ashamed of that gap. And there's a lot of reasons why those gaps can occur. It's not just, oh, the clinicians didn't do the right thing. There's, there's, co-payment, insurance, understanding, capacity to comply. So how do we think about the problem? This is a slide I really like because it reminds us that about 30 to at most maybe 40% of the outcomes that our patients experience are related to their genes and the drugs or interventions we provide. That leaves 60 to 70% of the opportunity outside of the place we have spent all of our lives training to do. And so I would argue, the prescription pad is not the solution. It's everything that happens after that. And I think you heard previously from Alexis and others, we need a different conceptual model. We need to start thinking about all the factors, what we call the social drivers of health originally. I really just think of as the exposome. It's everything that happens to our patients when they're outside of our walls. And lest we think this is only about heart disease, this is an editorial I wrote, opinion piece 7 years ago, about how we need a different model. And this is the case for secondary prevention for stroke, but it's not that different. The concept is we need to start thinking about the patient, their key caregiver or contact person, and their social network that surrounds them. That has an enormous impact on their capacity to comply. And then we need to think about how to make the mouse work. Interventions that can provide closed-loop, immediate feedback to patients without the mediation of an expensive cardiologist, healthcare worker. Maybe community health worker is a reasonable surrogate there, but if we can rely on the patient, their social network, and good technology, we could get a long way. And then the only time you need to invoke the program coordinator and the physician is when you get an alert, when there's an algorithmic output that says there's a problem here. If you can take that conceptual model and bake it into a financially viable, sustainable program, and by sustainable I mean not just that there's a financial ROI, but you don't burn out the family member, you don't overwhelm the patient with complexity. And when we're talking about complexity, I mean, having done this in small ways in lots of patient populations, forcing someone to have a smartphone, to download an app, to link it to their portal, and bond it to a device, you've now eliminated probably half the people who are experiencing that mortality, right? That is too complicated. We need to move complexity away from the user, and the program that's going to be presented by Chris Alchek after me has, I think, done a really nice job of demonstrating that there's a simpler way to do this. More complexity on the vendor or the model, less complexity on the user. And so we talk about how do we integrate med management mediated by closed loop sensing with a fully staffed clinical model. It might be the doctors at or the clinicians at your health system. It might be an outsourced model where clinicians dedicated to just that program. Clinical decision making, integration with the EMR so there's no fragmentation of care, and coverage, right? If you can make that virtuous cycle, you have an opportunity to change things. And once you plug in machine learning and generative AI, now you can start to create hyper-personalized interfaces for patients where you're speaking to them in their own language. You're communicating with them in the way that they have identified works best for them, at their reading level, in their language of choice, with their cultural values embedded. So it starts to get really interesting and really exciting. So how does this fit within the AHA? This is actually nested inside the mission-aligned business function, which is a really interesting way of bringing together assets you wouldn't have thought belonged together. You've got the quality registries, and when you think about the power of those registries, it's highly curated data. Data that can be married with physiologic data that can then produce these insights. You also have these relationships with other organizations. You have all the hospital relationships. You have patient impact, and you also have social drivers of health. This also becomes another model to lay on top of that virtuous cycle to allow you to actually start generating real opportunity at scale. I feel like it's all in the wrist, you know what I'm saying? Yeah, there we go. So the power here, in my opinion, is take what we know about the connection of patients at the hospital interface, where we have excelled in driving evidence to practice, and now try to just push that a little further into the home. Take that connective tissue and just stretch it a little further so that you maintain an embrace of that patient after they leave your four walls, because that's the challenge. You know, when you think about cardiac rehab and telecardiac rehab is about moving your body, exercising, stretching your cardiovascular system enough to continue to work that muscle. You don't have to, it's not guided by a CAT scan, right? It doesn't need technology, it needs that driving relationship, be it human, be it by an algorithm, but someone has to meet the patient, engage them, and get them to move. So we got to take that same principle and apply it here. What is it that will motivate Fred to check his blood pressure, or Nancy to take her medicines as prescribed, or John to actually call the clinic when they don't feel well, and instead of just assuming it's their medicine and not taking it? And ultimately, I believe the solution will be we take all the data we gathered about you in the hospital. We know we have most of that in Get With The Guidelines. We now push it back down into your app, into your account, and now we get hyper-personalized recommendations, because not only do we know you have heart failure, we know your ejection fraction. We know the history of the medicines you've been on. We know the ones that haven't worked. And so we're really almost bringing the information from the EMR, the insights, now into the patient's life, and as opposed to that being just a conversation between clinicians. So I will end by talking about this journey, which I think is evidence to practice and now back to home. And that's the goal. Thank you very much. And now Chris Alchek will come up and show you how this actually works.
Okay, thank you, Dr. Schwamm. Much appreciated. Today I'm excited to share what we've learned deploying a nationwide program to implement the heart failure, hypertension, and diabetes guidelines to over 43,000 patients in the last 3 years. This talk is about implementation. First, we'll talk about a new care model that implements the latest scientific advancements to patients at scale. Then we'll share the data from the largest RPM analysis on over 43,000 patients with hypertension, showing significant reduction in blood pressure and 70% relative increase in patients achieving goal. Last, we'll review the largest cost analysis and utilization analysis on RPM, showing $1,300 in average total cost of care savings, driven by 27% reduction in hospitalizations. That's on 5,800 patients compared to over 11,000 in a propensity match control. In our country, as the other speakers have shared, we have the ability to significantly impact chronic disease, but we systemically struggle to implement relatively simple interventions. Our system is not set up for success, as we know, whether it's clinical inertia, lack of time, challenges with adherence, inability to educate and coach, lack of actionable data. We have substandard outcomes in the US. The data points a stark picture. Dr. Schwamm just shared, but heart failure mortality from the early 2000s, we made a lot of progress. New discoveries, new medications improve outcomes. But since 2012, mortality has consistently increased. Our ability to provide guideline-directed care did not keep up with a population that became increasingly sicker and more complex. Our failure to implement the guidelines is most clearly evidenced in heart failure, as Dr. Schwamm shared the data. We know that getting a patient to GDMT will prolong their life by 5 years longer on average, yet the gap remains enormous. We've tried many things to solve this gap. First, we experimented with remote patient monitoring as a tool to see data on patients at home. However, it's become very clear that monitoring alone at the population level has not moved the needle. Without the ability to act on information being gathered between clinic visits, collecting the data has not today resulted in better outcomes. Many were hopeful that clinician decision support tools in the EMR would nudge providers to fill the gap that monitoring alone left. But however, because patients probably desired more individualized care, or because clinicians largely don't see patients frequently enough, this has failed to scale. Solutions that incorporate monitoring and treatment support, such as GDMT clinics, have proven very effective, as many of you know, but they're resource intensive and limited to only a fraction of the eligible patients in any health system. At most health systems, the heart failure clinics manage hundreds of patients despite tens of thousands needing that support. We need solutions that can manage hundreds of thousands of patients, not hundreds of patients. And remote patient care, the evolution from remote patient monitoring, can help. What is it? It's a collaborative model where remote patient monitoring and a virtual care team deliver guideline-directed care at scale. The key components are, number one, it extends, not supplants, the local clinicians. Number two, patients have 24/7 access to a nurse practitioner-led clinical team that can actually deliver the guidelines, prescribe medications, support with diet and exercise coaching, and big number three, it's fully integrated into the electronic medical record and financially sustainable in both fee-for-service and value-based arrangements. We launched Cadence in 2021, and we're now delivering remote patient care to 28,000 active patients as of this morning across 14 health systems in 29 states. And the data on patient engagement is really exciting. Patients in the last year alone have transmitted 8 million vitals, triggering 145,000 alerts, requiring 27,000 encounters when clinics are closed on nights and weekends, with patient satisfaction of 4.9 out of 5. Qualitatively, what we've learned is that patients most appreciate the peace of mind knowing that someone is looking over their care all the time between their cardiology visits, monitoring their daily vitals, answering health-related questions in real time, and moving the care forward. Earlier this year, we presented our results on 367 HFrEF patients, which showed a significant increase in both percentage of patients who achieve all 4 pillars of GDMT, as well as patients who achieve above 50% of target dose of each pillar, which we know helps patients live longer, healthier lives. In addition, using ACO claims data, a difference in difference analysis demonstrated that patients were saving on average over $1,000 per patient in hospital and post-hospital spending. Most recently, our data on our hypertension program, which is currently under review, includes 23,638 patients, of whom 57% live in rural and underserved areas. We're seeing a significant reduction in blood pressure and a 70% relative increase in patients achieving guideline-directed goal blood pressure, and similar outcomes across social determinants of health cohorts. This program is delivering improved clinical outcomes at scale. In addition to improved clinical outcomes, we're showing significant cost savings of $1,308 per patient per year. This is a separate analysis where we analyzed 5,800 patients in the remote care program, inclusive of all 3 conditions, heart failure, hypertension, diabetes, and matched them to a propensity score match control group of over 11,000 patients. Data showed 27% reduction in hospital admissions for issues that you'd expect: heart failure, complications of uncontrolled hypertension, cardiac arrhythmias, and infections. The data shows significant reductions in inpatient costs and inpatient admissions across multiple chronic disease programs. But I'll just end by saying this is just the beginning. I think this is the most exciting part about this conference and today. Technology and an innovative care model can deliver superior outcomes at lower cost, especially in rural and underserved communities where access is most limited. Further, these remote patient care programs more than pay for themselves. We will prioritize populations that have had historically limited access to high-quality, specialized, guideline-based care and hope to make a meaningful dent in our ballooning chronic disease crisis. Very much looking forward to the rest of the discussion today and your questions as we tackle these important issues. Thank you. And Dr. Peterson is up next. I'll try to, if you guys are going to fast forward, here we go.
So as a true understander of technology, I'm going to have no slides because I see the struggle that happens to my colleagues. You know, these heart association meetings are special. They always are a great time to come together with friends. This year is in particularly special as we look back over 100 years of the Heart Association and its major successes over that time and celebrate those. It's also an opportunity to look forward, something that's a little frightening these days, but in fact, I suspect the future will both survive the next 4 years and then go on beyond that to be an incredible time in the world. When I look at my opportunity here at the mic, it's an opportunity to look back. 10 years ago, Patrick Wayte, and Nancy Brown, who's joined us, and several others joined in Boston for a sort of interesting event. It was the first time we ever got together under the Heart Association banner to think about how can we bring technology leaders from around the world as well as clinicians and bring them into a room and talk about that interstitial space between those two worlds. How could we bring them together and make it work? And lo and behold, that became the driving force behind this group that you see today and where it's come to. Over the last decade, much progress has been made. As you heard from Mujeeb early on, many companies have joined in, and instead of being companies and doctors and healthcare providers, it's become a group that's thought about how can we innovate, how can we move fields forward. And that's in fact what the Heart Association as an organization does actually best, a convener of forces that traditionally have been separated but now brought together. And we're starting to see the fruits of that labor. As you'll walk around the booths here today, you'll see incredible technologies that are not just incredible in themselves, but are solutions to healthcare problems that face us every day. Just as our last speaker talked, it's an amazing sort of combination after the first opening session where we talked about the importance of blood pressure monitor or control for patient populations and how much that can mean. Now we have companies coming out with solutions that can help bring down that pressure. You'll see this across a number of different challenges that we face as healthcare providers every day, now thinking about where can we use technological solutions to make that happen. But as we look forward, I think the other thing the Heart Association does is think about scale. How can we actually bring this to all individuals across the country? Right now, we face a huge digital divide. There are people who are haves and have-nots. There are people who are living in urban centers and high-tech centers, and then there's rural hospitals who are struggling just to keep the doors open. So how do we get those technological solutions, once found, out to the rest of the world? And again, that is what the Heart Association does so incredibly well, to both disseminate knowledge, but then think about creative solutions that will encourage and empower these small institutions to develop and use this technology in everyday practice. So as we look back, we can be proud about what we've done so far, but we can be even more excited as we look forward. So with that, I think we'll get us back on time, and we'll sit down.
Okay, let's see if I can get the technology to work here. Hello, good morning. I'm Jeff Bennett. I'm the Chief Strategy and Innovation Officer at ModivCare. We provide monitoring services for about 250,000 people at home, along with a community access network that provides screening and monitoring for to enable screening and monitoring for about 250 million free sessions where people have screened 250 million times in the last 10 years for tens of millions of Americans. So that's the platform that we're going to talk a little bit about today. I'd like to thank Patrick Wayte, Pat Dunn, and CHTI for the opportunity to speak today as we're collaborating with the AHA on how to bring access to care to rural and underserved communities. And I'd also like to thank all of you for joining us today and ask you to join us because this is going to take a full village, if you will, to address this issue. Before I get started on my presentation, I want to talk a little bit about the access problem. So for me personally, my dad had his first heart attack when I was 11. He was 42 years old. My uncle died at 38 years old. 9 days later. So within 9 days, 2 heart attacks. I was diagnosed with cardiovascular disease at 35 years old. I was diagnosed with prediabetes a year ago. I've run 43 marathons. My blood pressure's in control. My glucose is in control because I have access to doctors. I have access to education. I have access to a CGM that I wear. That's not the access that most of this country gets. So that's just giving you an example of the access that we need to bring. Okay, here we go. So what is the access problem that we have today? When it comes to health, our rural and underserved communities are being left behind. If you look at over the last 20 years, almost 200 hospitals have been closed. If you look in the future, 700 hospitals are at risk of closing. This is an access to care problem in rural America that we're not going to solve with the current mechanism of how we're doing this. If you look at urban underserved communities, Chicago, where we're at, where I live, where our offices are, downtown Chicago, the life expectancy is 16 years higher than if you go 5 miles west. And it looks like the reason for death is heart disease, stroke, cancer. I'd argue, and actually the former Chief Innovation Officer at Rush would say, the real cause of death is access. And the Chief Innovation Officer also said, you know, the number one killer in Chicago isn't guns, it's hypertension, right? So these are the issues that we need to address. Here we go. So what's the problems we're facing? First is well over 100 million Americans lack access to primary care. That's a significant issue that isn't going to be solved through traditional means today. Second, half of Americans are underinsured or uninsured. They're moved in and out of different insurance. So there's not really one sort of stakeholder that's looking at them trying to manage their health over time. Third, our health systems, which have been a lot of times a safety net, the organizations that are investing in the community and addressing these core issues have been basically somewhat bankrupt during COVID. So a lot of those resources, a lot of those community hospitals are closing or don't have the resources they had before. And finally, some of the hope for some of us was that retail healthcare was going to solve this problem. And several of those organizations have exited, especially the ones in rural healthcare markets, have exited healthcare in a broader way. So this is the challenge we face. There's another challenge we face, and this is a study that was published on individuals that were 65 and older, so this is that cohort. But when you look at the people that we're trying to manage and trying to help on a regular basis, and you look at the people that are causing the major issues this year, what are the cost factors? And we always know that 5% of the population is 50% of the cost. But what this study showed is that if you look at next year, 75% of the members that are going to be high cost came from mid to low risk. So you can't just focus your efforts on sick care. You can't just focus on the people that are sick this year. You have to bring a much broader offering to find those members, educate them, and get them the right care. So we are collaborating with the American Heart Association to build a community care model for the rural and underserved populations. This includes taking the AHA science and content and deploying a screener, a Life Essential 8 screener, that can be accessed through mobile, through web, through QR code. Ask the questions that are relevant and provides AHA content and navigation to resources available to you. So this really allows us to understand the risk factors and the needs of people on an individual basis and give them personalized content to get to the right resources. Second, deploying health stations in rural and underserved areas to provide access to care. This provides the same capabilities that you've known if you've seen a Higgy station over the last 10 years, but now it also unlocks the ability if a health system or a provider wants to, we can actually provide a doctor right there. So you can basically have almost a virtual doctor's office in a box. And then for those that have access issues and maybe can't get to the station, we can unlock and send digital devices to the home, along with programs that include coaching or care management, and do home monitoring. So we're actually doing this 3-part program for community access in rural and underserved communities. Sorry. So with this, here's the examples of the programs. So first, we've taken the content from the AHA and built a health guide program. This is something that's free on the station. When you take your blood pressure, you can join the health guide program. You can pick the content that you want, whether it's smoking cessation, medication adherence, nutrition, physical activity, stress and anxiety. So we take that content and give it to you right there at the station. Or if you have a mobile device, I can give it through text on a regular basis to engage with you and come back on a regular basis. Well over 250,000 people have joined that program free for the users in the community. We've also deployed screeners, Health Within Reach, Vaccine Guide, Pharmacy Guide, and then the Life Essential 8 screener in that program. So these are all examples of bringing that content and then personalized navigation to the community. Okay, here's an example of the Life Essential 8 program. So what you're seeing in this program is a nationwide program that's across the entire country that's been deployed. The data's out of date because we had to present these like 2 weeks ago. It was 40,000. Now there's almost 50,000 people that have used this. And we understand some of their behaviors that are causing some of the issues. We understand their race, their ethnicity, their age, their gender. 10% of the users are young, 30% are between 30 and 50, 50 to 65 is another 30%, and then 65 and older. So it's across all ages. And then we can look into it and see what their issues are. We can see whether or not they're having hypertension issues or blood pressure issues, having weight issues, and then we can give them personalized content and education. So this is an example of a screening program that can really understand the community at broad strokes and then drive personalized navigation for each of them. Another example of a program that's been deployed is deploying a station in an underserved community location. This was done in Chicago, where we deployed this in a homeless shelter. If you look at the data, it's probably hard for you to see, but we screened about 80% of the people in the homeless shelter, and the national average for the almost 400 million blood pressure results that we've gathered over the last 11 years on the Higgy platform is 2.2% of the people have a reading that would indicate hypertensive crisis. In this homeless shelter on the west side of Chicago, in a very underserved community, almost 9% of the people had a hypertensive crisis reading. But what that data did is it went right to the EMR, and it got a doctor, a medical director, an NP, a medical student, to come to that location, sit down with that homeless person, explain to their issue, gave them the medications. Within 9 months, we took that to about 1% of the population. So an underserved community center location that was helping the homeless had half the volume of hypertensive crisis than their whole country did by bringing access to them instead of bringing access to bringing a hospital to them, and bring them to the hospital, meet them where they are, if you will. And finally, very aligned with what Chris just mentioned, deploying programs at home, not just around monitoring, but deploying programs that include care management. So I like that remote patient care. Good analogy. I'll go with you on that. It's not just remote patient monitoring, right? But deploying this, we got a grant from the Michigan Center for Rural Health to bring this into the homes of people. So this is about 100 people that we deployed, about 70 actually to be specific. And what we saw with that is very high engagement of coaching, doing that care management, understanding the care plan, making sure what the doctor's saying and bring that to the home. So 90% of the people got that care management on over a year basis. 75% participated in their 16 screenings or more a month. And in fact, we got a reading per day per user across that year. But we doubled the number of people that were in control for blood pressure. We reduced blood pressure, we reduced glucose, we reduced weight through this population. And through what Motive Care offers, which we're the largest provider of NEMT, we have 15,000 caregivers that go in the home to do ADL. We have PERS devices that can help you with risk of fall. We identified S2H factors. 58% required transportation, 90% had a risk of fall. So we can actually address those things with our services or the services that our plans offered. So where are we going with this moving forward? We are, as Motive Care, working with the AHA, and we're taking this out to our network. Our network within Motive Care is we are the provider of NEMT, of non-emergency medical transportation, for 14 states across the country. We also provide services through monitoring capabilities, our home care, and through our transportation to 8 of the top 10 Medicaid plans, 9 of the top 20 Medicare Advantage plans, 3,000 AAA organizations, and 5,000 retail pharmacy organizations. So we're bringing this platform out through our channels. And then we're partnering with the AHA to engage and talk to health systems, to talk to state agencies and our MCO customers, and also philanthropic organizations to help us really bring access to care to all. Thank you. If there's any questions now, I don't know if we have a minute or two, otherwise there's going to be 2 breakout sessions, and I'm going to hand it to Pat to explain that.
If anybody has any questions, we can do some Q&A. Otherwise, after that, we'll break into the roundtable discussions. The way the roundtables will work, Chris is going to be at one table, and Jeff will be at the other table. And the premise is to invite audience participation. So you can pick a table and have just more of a regular conversation. But does anybody have any questions for the group?